I'm gonna call the Finance Committee for October 27, 2001 to order. And see if there are any changes to the agenda, even if we're bumping somebody up or moving the order of it.
I don't think we have any of that today.
Okay. When I act like I'm prepared for it. You know. So going to request if there's any approval to the minutes, if there's no corrections to the minutes of September 29th, 2001. And if the minutes are approved as distributed.
Move.
Okay. Do we have a second? Do we need a second for that?
I don't think we need a second, but I'll second if we do.
All right, well, good. This time is time for public comment. I didn't actually see anybody on, but then that doesn't mean anything. So if there is anybody here from the public that would like to make a comment, now would be the time. It's the portion of the meeting is reserved for persons to address the committee on any matter not on the agenda. They may ask a question for clarification, make a referral to staff for factual information, or request staff to report back to the committee at a later meeting. But I don't see anybody here. Heidi from the big screen, do you see anybody?
Nope.
Okay.
That's today.
At the last meeting, Russ said that the board members were public, but I don't, Russ, you're there now. I don't think you or Fred can comment, or can you, since you're there?
Well, they're not going to comment now, Steve. I mean, Steve.
You know,
They don't even want to talk now.
Technically, we can comment during the public comment section, but we can only talk about things that are not on the agenda. So,
right.
Okay.
That could be a good thing.
So now we're going to go to the financial statements from August 2021 for the monthly finance report. Those are on the pages 6 through 19. Actually, from 6 all the way to 25. Is there anything there that we need to speak to? Because that was actually the September ones, correct?
Yes, and I'm on the agenda and I can jump right in.
Okay.
So I'm going to hit shared screen. And hopefully you can see what I'm looking at. We're on page 8. Can everyone see that?
Yep.
Okay, so we have a new green cursor. Can everyone see that?
Yeah.
Hopefully it's big enough. So all I wanted to say on this page is going down to the statistics. On a year-to-date basis, we continue to be real strong in this first category: total acute patient days 402, budget 290, and also on the emergency room visits 1961, 1837. That's still about a 15% favorable variance. Even compared to last year, it's much higher. So the first quarter of the new year has been busier than what we expected and what we had the prior year. And it's translated favorably into this total surplus line that shows 1.4 million compared to the budget of 183, or about a 1.2 million favorable variance after the first quarter. Any questions on this page before we move on?
Now that 1.4 or 1402, 22.
Yes.
What I have asked Chet many times was to make a chart of the health of the hospital on a chart that the public could look at without all this stuff. They can't look at all this stuff. I can't look at it all. And so
we could start creating pages that have less information on it.
Well, no, you could do that. for everybody's information that's involved, but just something for the public to show the health of the hospital as it goes up and down.
Yeah, I can start working.
Saying?
I can start working on that. I've seen those in the past, and they can be a lot more helpful than showing all this detail.
Right. And the average person can say, hey, we're doing good, or we need to help the hospital if it's starting to dip a little bit. Tim, is that a reasonable thing?
Absolutely. I think it's a great idea, Gene.
So next month, I'll show you guys a draft before we actually start showing the public that, and we can play with it.
Okay, and there's plenty of time.
And that ties into what we were talking about the other day with regards to our communications to the community. I think obviously being able to portray that we've got good, strong, healthy financials is really important.
Absolutely. So, okay, so we're going to move on to the next page. This is the new one that shows the graph of how our financial strength has improved since 2019. That continues to show the same type of change, and I just lost my picture. So my fingers. Okay, are we back?
We never
your cursor's moving, so.
Okay, so I'm going to then have you look at my positive and negative takeaways on the bottom of that page, and you can see that we really did a good job of the last month paying down our trade payables. The new level on the assets, 1.7 million, is about as low as I've seen in quite a while. So our AP is down real good. Our bills are paid off very quickly, and we've been able to get a lot of that cleaned up.
Okay, so we are paying our bills as we get them.
We do, but sometimes there's big ones that need more research, that take a little bit longer, that ends up showing a higher balance at the end of the month.
Yeah, well, this is one example, and I've talked to Barbara about it. I don't want to beat it to death, but in May, the gas company, we had a couple bills, and they were paid in 4 parts.
And sometimes there's going to be extenuating circumstances. Probably even a worse thing than paying our bills quickly is paying a bill that should have never been paid, and we never get our money back.
Okay. So
it's a trade-off, but right now we're in real good shape. Barbara has really done a good job that we have a real low number on a relative basis of what our AP balances are. So it's something that we can be proud of and not apologize over. We're very fast compared to other organizations on how quickly we get. Can
I make one other comment?
Okay.
Barbara looks 10 years younger since you took over. So you have been a big benefit to her.
Well, she's doing a great job, and it really makes my job easier because we have such a good controller.
Yeah, cool.
Okay, on the negative side, obviously the 1.2 million variance to budget is one of the positives on the net income. On the negative, we are seeing some higher expenses in certain categories. We did have higher purchase services and supply costs, and I looked at some of that detail, and a vast majority of those were COVID-related higher expenses that wasn't the case before COVID was around. The types of new expenses that we have now. Thankfully, we're getting all the supplemental money is more than offsetting these higher costs in miscellaneous categories like purchase services and supplies. So we're getting paid in a different way back, but we are showing it on the income statement as a variance against budget because it's higher than it has been in prior years in certain categories. Accounts receivable, it's kind of a mix. I looked closer at the accounts receivable this month, and even though the gross numbers are going up, if you look at it on a days basis, it's actually slightly down from where we finished the end of June. So it's kind of just leveled off. It's still higher than it should be, and we're going to be spending some time looking at that, but it is continuing to put it into a negative takeaway category. The third line item, just as a reminder, our cash position is being adversely affected because of the first quarter supplemental funding. The actual cash coming in has been very low so far this year. Any questions on that page before I go?
Is it low because we got an advance? Are we able to use the money that we got?
Yeah, that's a good question.
The advance.
Thankfully, all those advances are in the bank account, and they could conceivably be used for anything we need it for if we had to. So it's the timing is okay for us to have a little bit of a lull in with the receipts being lower, because our starting point is very high cash balances because of what we received the last couple of years with all these extra payments.
Did you segregate the IGT advances from the regular IGT payments?
Yeah, so Barbara could better answer that question, how she has that sequestered on different bank accounts. We normally wouldn't be taking money from any of those special funds and use it for normal operations, but technically it is available to be used if we had to.
Okay, and on the thing you're going to look at, if you could not put advances into it, put the real figures, the IGT that we're getting, that's ours.
Yeah.
And not
I like that too. I like to when we talk about IGTs, I like to talk about what we actually netted out, and would be a more meaningful number.
Right. So we know if we need to work harder or whatever. And Tim's done a good job, but we might make him work harder.
So I'm on page, the bottom of page 3 is actually page 10. So we're on page 10, and I'm looking at the assets. I added a new section on this page, and I'm going to point to it. Right on top here, net to gross AR percentage. The reason why that's important and why I'm highlighting it is it's an indicator of some very big numbers on how they're estimated. So the two biggest numbers on our assets is this line item 2, gross patient accounts receivables, almost $30 million. And then line item 4 is the net accounts receivable of $6 million. What this is saying is that $6 million compared to the $29 million that out of what we have in AR, we expect to collect 23.0%. Now, the reason why that's important, because out of every part of the financial statements, this represents the largest where we have to estimate, because nobody knows for sure exactly how much we're going to collect of this 29 million. But based on detailed formulas, we've come up with this 6.8 million number. And the reason why I like to look at it is it helps me confirm whether or not this number is a reasonable number based on detailed empirical study AR logs, where we can analyze the percent of actual payment we get when the insurance payment comes in on a patient account compared to how much was billed. And we have a consistent number of what we're seeing here of about a 23% average payment of everything that gets billed out to patients and insurance companies. That we get about 23% back. So this number is consistent with what we're seeing in the empirical study on our AR logs.
Are we seeing any kind of a significant shift in mix? Because obviously mix makes a difference there in terms of what you're seeing in that number.
What we're seeing on the AR side is that I'm going to show you later is an improvement in less amount of people without any insurance at all. So you'll see the self-pay balances being less than they were, let's say, 6 months ago.
Yeah.
Which is a good thing, because you don't want, if you wouldn't want all 29 million of that money on patients that don't have insurance. Obviously, you're not going to collect a whole lot. So the overall quality of the AR has improved slightly because there's a little bit less self-pay than there was a few months ago.
Now, the numbers, because it's so low, is that because of Medicare? We bill a full amount and then we end up getting 30 cents on the dollar?
Yeah, Medicare and Medicaid, the state and federal payers are extremely low, especially Medi-Cal. You know, on the outpatient side, you're lucky if you get 10 cents on the dollar. So,
well, there's another aspect to this too, and that is that, you know, again, the hospital has routinely submitted a 7% price increase each year, you know, in an effort to try and capture as much revenue opportunities we can for things that are still paid on a percentage of gross charges. Very few of our payers actually pay that way anymore. So what happens is, while you raise your prices 7%, your net reimbursement from your health plans is not changing at that percentage. So that's why that rate will over time continue to decrease.
And the reason why it would be important for me to take the time here in Finance Committee to a Finance Committee board member is that this is something you should also keep an eye on, because I should have a good explanation for you if that number deviates significantly from the 23%, either up or down. You really don't want to have numbers that we had in the last few months where it's significantly higher than that, because that means you could potentially be overstating your bottom line by expecting to receive more of your net patient receivable than you really will be able to collect. So I wanted to bring that number down to a number that fits into what we're actually seeing when we take the averages of payments coming in. So that's something to keep an eye on because of the significance of the dollars that are impacted on the estimates. Does anybody have any questions on that? Why it's significant?
Just one question, just sort of get things set in the way you understand. Whenever the numbers went down and we weren't doing that good, we would beat up Chet.
Sometimes my point is sometimes it's just a math error that somehow we calculated it wrong, and we need to look at the formulas, and we need to make sure those estimates are accurate. I'm not suggesting that whatever shows up on this line item is actually what's being collected. That's a whole different analysis where we look at cash collections compared to adjustments. This is something else where we have to try to estimate future cash collections.
I was trying to make a joke about Chet.
Yeah, and that's a good point. We all have to be held accountable. We're not collecting as much, and you know, and the business office knows that, and they take it seriously. Sometimes we're okay with the AR staying higher if they know they're going to collect more. What we don't want to do is incentivize the billers to just write everything off and say, I got low AR, but then I have to say, but you didn't collect anything. You wrote it all off. So we really don't mind them taking the extra time if they can get more money from the insurance company. So that's just you know, it's kind of one of those trade-offs. Any other questions? Okay, we'll move off of the assets. And I just want to check my notes here, what I have. On the liabilities, I just wanted to reemphasize this number right here. 465,000 less in accounts payable. That's the bills that we've been paying quicker. So that's a real good number on accounts payable. Okay, let's move on. So I don't have anything on 12. I'm going to move down to page 13, which is the financial statements just for the month of September. And you can see the bottom line, 470 compared to the budget of 50 was a good month. similar to what we had the last 2 months, where we had favorable variances on all the revenue, 3% higher than budget on the revenues. And then the net patient revenue is actually 18% higher. So even before you count the expenses, we were already quite a bit ahead of budget. And then on the expense side, we were actually below budget again this last month. We have a few line items in the red where they were higher, but because salaries and wages were so much lower, it netted out 31,000 less on expenses. So the month of September, similar to the last couple months, is keep staying on the same trend as it relates to profit loss. I'm looking, now we're going to go down to the next page, which shows the year-to-date information. And that's page 14. And we have, I try to look at a trend. We got a quarter of information now. And I like to look at this number right here on line 11. The actual number for the first 3 months, 9,135,000. And I like to compare it to what happened the first 3 months of last year. And you can see it's significantly better. 9.1 million compared to 7.5. That's the amount of business coming into the hospital. So definitely you can say the first quarter in terms of revenues and volumes generated a high percentage greater than the prior year, 9.1 million net patient revenue compared to 7.5. So that's what we could call a growth percentage.
The long-term care hasn't been performing.
No, that one's been kind of just holding its own, but not really part of the growth like the other categories are at this stage. What I am seeing is a high number of patients that are in a holding. I don't quite understand it. They're going to be admitted as soon as there's certain criteria that is somewhat affected by COVID. I didn't really understand.
As long as we're in a yellow or a red zone status, we can't admit new patients into the unit.
So that's really more than anything.
2 weeks worth of negative tests before we can actually start admitting in there again.
So if we didn't have that as a constraint, I think we'd be in good shape, is my point. So, which means the demand is there for people want to come here. And it's just a matter of being in the colored zones that we are right now.
Mark, any idea where we're at time-wise before we're out of that situation? Do you know?
We had 3 positives within the last 5 days. So we're looking at least, I'm just kind of speculating. It could be 2 weeks, providing we don't get any more positives.
Yeah.
We do have some swing beds on acute care that are awaiting those beds. So it's, once those are freed up, we will have some admissions for them. Yeah, it's.
So that's one of the main things, not causing the skill to also be a growth area, which again, as soon as all this is over with, we're likely to, because the demand is there, be in good shape as it relates to filling up our skilled beds. One other thing I wanted to point out is line 19, and again, COVID related. This is a pretty big percentage variance, 14.66% variance year to date on our supply costs. And again, a lot of that is COVID related. Any questions on this page before we move on?
Can we go back and look at contract labor just for a second?
Sure can.
Because I just want to look at some numbers from in line 16 there.
Yeah.
The numbers that were prior year versus this year, those can be kind of, the fact that our registries had gone up exponentially this year is, it doesn't mean that we're using more, we're just paying more for the same service.
That's
It's
good
incredibly high.
Yeah, good point.
Excellent point. So, and we can see that when we look at paid and worked FTEs, our actual worked and paid hours is not high, but the dollars, especially as it relates to contract labor, you can see are up 100, almost 100,000. Good point.
Thank you.
Any other questions or comments? Okay, we're going to skip through these 2 pages and we're going to move to the statistic. I think we pretty much have covered the statistics. When we looked at the executive summary, I don't have anything more to add on our volumes. I do want to comment just a little bit on this page 18. You can see I did some color coding. For those people that are really interested in that financial strength index, so if you really wanted to know more detail than you'd probably ever want to know about that formula, these are the 4 line items that it looks at to gauge whether or not a hospital is financially strong. Number 4, they want to know your total profit margin. Now, it used to be year to date, now it's a 13-month average. Number 11, they want to know how much money you got in the bank from all sources, and that's a, and again, you see I added this new column here, favorable. So sometimes you want the number to be higher the better. Sometimes it's like golf, you want to be the lower the better. Like number 5, contractual allowance, you don't want to have a high contractual allowance percentage.
Oh, and that's what I was messing up in my golf game.
Yeah, you got to shoot high, Mark.
So this kind of helps a beginning reader understand, well, is this a good or a bad number if it's compared to prior year or California standards, and now you have a column to say you want it to either be higher or lower. The other 2 categories that are part of the financial strength index you can see is average age of plant. If you haven't done anything to improve your facilities, the organization is going to eventually financially suffer from that. So as we get farther along on our $19 million project, our average age of plant will get better and better as we put money into our fixed assets. And then the last category is you don't want to have too much long-term debt compared to how much money you're bringing in capitalization. So those are, that's kind of what makes an organization considered to be financially strong. Now you're an expert on that. You can go to your neighbor and tell them, you understand financial strength index. This next page is a section where I did have a couple typos that I want to, we'll probably fix it for the full board packet, but this whole top section is all been revamped based on new detailed information that I'm going to show you in a minute or 2. So especially you can see there's one as a reference, line 3, and I have the new numbers. They're slightly different. This one's 86.52. This one's 115.99. This one's 83.98, and this one's 76.3. The reason why I'm taking the time to tell you that verbally, and then we'll fix that in the next version, is what we're going to spend the next 5 minutes or so on is looking at detail of gross accounts receivable by patient type, inpatient, outpatient, long-term care. So we're going to look at all that detail, and we did all that. We did all the detail, but we didn't update this section. So we're going to be fixing that in the next version. So I apologize for that. So here is what I'm talking about, starting on page 20. So pages 20, 21, and 22 is a lot more detail than you'd ever want to know about how you calculate days and accounts receivable. And the main benefit to looking at this level of detail is so that when you have problems, you can zero in on where the problem is and find out why one particular payer on one particular type of service isn't paying you, and how you're billing it wrong, or what what is going on specifically that's causing the payments not to come in as quickly as they should. And looking at trends also helps you analyze, well, gee, 3 months ago, this payer was paying me a lot faster. Why aren't they paying me like they did, the 12 months before or something like that? So when you get into this level of detail, it helps develop a strategy that I can sit down with the manager of the business office, and we can start going through a number of scenarios to figure out how we can improve the AR. So what is this report doing? So I'm going to go back to the top again. The very top section is merely just shows how busy we are by payer in terms of what we bill the patients. Total gross charges of 29 million year to date for the first quarter last year, 31 million. And this is split up by what payers are getting those charges. That's how busy we are on each of those payer groups. And you can see that obviously the Medicare and Medi-Cal line items 4 through 7 is the vast majority of our business is either state or federal government payers. And sometimes that can be a good thing, sometimes it can be a bad thing. In general, what we're finding out with accounts receivable, if I make a summary statement right now, that all organizations since COVID started has become less efficient both at the provider level and at the payer level with getting all the detail into the system and necessary information before a bill gets paid. Just about every hospital CFO I talk to, their AR is also higher than it had been pre-COVID. So we're not the only ones going through this where we have higher AR, and it's due to some other extenuating circumstances like the inefficiencies created because people are working off site and all kinds of other issues to get the right people to do the right things on the bill to make it a clean claim. The next section is Dave,
can I ask you a question on that? It looks like a whole lot of self-pay there. On the,
yeah, there is. And we generally 6 to 8% of the patients, but the percentages for Kern Valley is actually a little bit less than what I've seen at other organizations. It's just part of doing business. You're going to have people show up at the door that don't have any insurance at all. And that's why your bad debt number always every year is in the 7 figures, is you just, they just can't pay their bill and they know it ahead of time. They don't have the insurance, and it's just part of how healthcare has always been.
Where we bill Medicare and then we bill the other 20% to Blue Cross, is that split out into insurance and Medicare?
Good point. These categories represent the patient's primary payer. So if they had insurance, all of their account would just show up in the one bucket for that particular insurance. It wouldn't be split up because they had a copay. The only time self-pay would show up is if they didn't have insurance at all.
Okay, thank you.
The second groupings, 9 through 16, kind of just gives us a trend of how high our AR is. It's 29 million now. It was 26 million back in June. And what specific categories have gotten higher or lower? It's jumping out at me a little bit. The senior HMO has gone up quite a bit, almost 10%. And the same thing with Medi-Cal, line 13 has gone up 1.3 million, like 15, 20% for Medi-Cal. So we would need to be digging deeper when I meet with a business office manager. We find out what's going on with Medi-Cal. Why have they slowed down their payment so much? And then we might even take a phone call to the state in Sacramento to find out what's going on, why we're not getting these bills paid. So I've done those kind of things in the past, and it just takes a little bit more resources and assistance to the leadership of the department to help them get through times when the balances start getting high. Any questions on this detail? What it does also do is we created a target. I looked at the last recent history, and we have a really good month back a little over a year ago in July of 2020. Our days were down 77. So we can at least set some targets for the billers to say, hey, look, let's get back to where we were a little more than a year ago. Let's see what we can do to get it back down to 77 days. And then from there, we'll set up another target even lower once we hit that first target, to give them some motivation to and start showing these kind of numbers to the people in the staffs to give them some motivation to improve.
Dave, just from your perspective, what do you believe is going on with Medi-Cal? Because Medi-Cal usually is a pretty quick turnaround.
Yeah, I think it's a couple things.
Jumped up to 94 from the 76.
I looked at the detail. I'm going to go down to the inpatient. That was grand total. That page 20, page right. 21 is inpatient. Now, if you look at the Medi-Cal AR, which is line 13 here on the inpatient side, it doesn't look too bad. Skilled is looks like the main problem is in skilled. So then I got to drill down and find out, why aren't they paying our skilled Medi-Cal bills?
Right.
So that's how we start the process and really trying to figure out what's going on and what has to be fixed. I think outpatients also, see what outpatient looks like on Medi-Cal is actually down a little bit on the outpatient side, 1.9 million, 2.2. So that's the benefit of this level of detail, is we can kind of look at trends and look at what's doable. The one other conclusion I came up with, when I've done this at other facilities, I usually take the time, and I haven't had the time to do it here, to verify whether or not charges are going into the correct buckets that the AR is going into. I suspect there's some incongruencies, so it's a little less meaningful to look at the detail by payer for days. These days section here might not be all that accurate, so I'm probably not going to break out inpatient, outpatient, and long-term care by payer, by days, or by on the days section, because I'm not sure how reliable it is. It only works as if when the patient comes in and they get registered, that the insurance would never change. That oftentimes they show their card and we find out later that a different insurance pays the bill, and that doesn't get fixed in the system the way it always should. So sometimes that really makes these kind of reports less reliable if you look at too much detail. So the general trends of what's happening in the various areas are still beneficial, but we might not quite show this much detail because it might not be accurate when you look at it the days by payer. So that's what we're working on operationally. And that was the end of my report for September before we turn it over to Barbara. So I'll ask if there's any other general questions of what I can explain.
I have a question, Dave. Do we keep track, and this goes back to Medi-Cal, because if I remember, Medi-Cal doesn't pay us until we have collected the share of costs from the patient. Is that correct? And so, go ahead.
No, go ahead. It's the cost. The whole cost section is a kind of a complicated answer because it's retrospective, and it's usually a couple of years down the road on when they pay us the cost. So it really is a confusing type of question. I don't know, Tim, do you have a better answer?
No, I don't. I think I know where she's coming from with her question, though. I think the question really has to do with a procedural issue in terms of, in other words, Medi-Cal is going to hold out until the patient has paid their responsible portion.
The patient.
That's what she's asking. Yeah.
Oh, the patient has a cost limit.
Cost, right?
Oh, yeah.
Yeah, the patient's the share of cost, if I remember correctly, the share of cost needs to be met by the patient, like a co-payment, before the insurance pays the rest. So with Medi-Cal, it's the same way. So are we collecting timely share of cost in order to bill and get the rest of the money from Medi-Cal? Is that part of the issue of Medi-Cal being not paying as quickly, or?
I will look into that. That's one possible thing that could be causing it to go higher. I have not dug into the business office yet to be able to answer a question like that, but that would be a good starting point where we'll dig into that and see if that's one of the factors.
Yeah,
Can I comment? Can I comment?
Yes, please.
Yes.
The share cost, Catherine, is our responsibility to collect, whether we collect it up front or after we've presented the first bill. It's up to us to collect. The first bill will deduct the share of cost, so Medi-Cal will not pay that. But besides that, your SNF cannot be paid until there is an approved TAR through the system with all the backup and work that has to be done to get that patient admitted to begin with. And that could take months. So you may not get paid on that patient for months just because the TAR has not come back from the state. And they're working from home too.
And a TAR for those is a treatment authorization request.
Yes.
Approval.
Yeah, no, I understand that process. And I do know that it is the hospital's responsibility to collect, because been there, done that.
We will show it on the first bill of the month as being paid.
Okay. Okay. I just didn't know if that had something to do with, the numbers. And I know it takes, and the MDS has to be attached to the TAR.
Exactly. And it has to be complete and accurate.
Accurate. Right. I understand that. So I know that there's a lot of process that goes into it. And I know with issues with, staffing and different things and everybody doing their portion with MDS is that it takes a while. I'm just thinking that may have something to do with the numbers because of the process takes so long. I mean, there's not anything we can really do about that, but I think it is a process, part of a process issue, not something that we could probably correct right away or anything like that. But I know it is a process. And I think that may have something to do with, the different, the numbers or sometimes them taking longer. And a TAR is good for 2 years after it's approved, maximum.
I don't know about the maximum, but yes, there's certain things that have to be renewed at certain times. And I don't specifically know that. Okay.
I think the TARs before used to be at least every 2 years. So, okay. Thank you.
Thanks, Barbara. Any other questions? Okay. So I'll turn over the cash flow section. Barbara?
There's 2 pages on the cash flow. The first page, 23, shows you the 12 months with the first 3 months at actual and the rest of the months at the projected numbers so that you can see if everything goes like it is and continues throughout the other months, where we'll end up at the end. The second page is specific to the month, and it shows you what was projected for the month and what actually happened with cash. So we collected 2.2 million, 591,000 of that was other, which the biggest majority of that was the final payment we received on the CEC, which was 367,000, and a IGT NDPH payment for fiscal year 1920 for $147,803. So that's non-AR related cash. The total payments that we made, if you go down to the total payment line, was $3,349,820. And you can see up above where the expenditures were made. We are paying monthly on our new bond at $100,000 a month so that there is funding in the bank to make those payments when they come due. So we ended up with our other, after our other non-operating cash with $10,156,000 or 90 days cash on hand. Does anybody have any questions? Dave have comments?
Yeah, thanks, Barbara. The only comment I wanted to add was the projection months on that page 23, when we get out more toward the end of this fiscal year, we're showing a miscellaneous couple of months, 4 million here and 4 million in June. We don't know exactly. That was based on history that Chet put together. We know in general that some of those payments that happened last year aren't going to happen to the level that they happened last year. So it may be a little bit overstated because that was the way Chet normally did it, is he just looked at prior year. In this case, we probably should have adjusted those numbers. So I don't want the board to get unnecessarily too optimistic that those will be months where we get really huge amounts that come in. We're not sure yet.
Those were tied, Dave, to when we typically got our IGT payments made.
Yeah.
And so that's when those were adjusted. That's where some of that historical came in. So
well, I just wanted to give you a heads up ahead of time so you're not surprised.
Where we anticipate that we're going to have less this year because of the state's change in their calendar year. Yeah, so you should expect to see some lessening of that down the road.
We'll probably change the projections next month. We'll tighten that up so we can get a better idea of what we know today.
Good idea.
Dave, when they started the IGT back in the 90s or whenever it was, we had a couple of clinics that didn't make nothing. We were a poor hospital. So our reimbursement is very, very favorable. It's subject to changing. They haven't changed it for over 20 years, so it seems pretty solid, but do you have any insight into that?
The experts, when I go to meetings, they're all giving us the caution sign that the horizon doesn't look as rosy, that this is an area that might start getting some severe reductions, but it's nothing for sure yet. But that's what I'm hearing.
That would be pretty serious for us because we got very favorable reimbursement.
And that's why healthcare organizations in general need to be just really soberly mindful of, because we rely so much on this kind of money. I need to get a little bit better responses back from the state. The way they're talking doesn't sound like, they're not saying the right things as far as the providers are concerned.
Right. Tim, you haven't mentioned, you mentioned that Chet's probably not going to come back. Is Dave permanent now or?
Not, we're working on those discussions. Probably because of this being a public meeting and so forth, I shouldn't probably talk about that.
Okay. Because he seems like he might be smarter than me. That would be a bad thing to hire him.
Thank you so much. You want to be my agent,
No,
I appreciate that. I'm happy to be on board, and I look forward to a good long-term relationship here. It's especially for me because Barbara's so good at what she does. It really makes my life a lot easier. Anyway, what's next on the agenda, Heidi?
We have the local vendors.
Yeah, local vendors.
Does anybody have any comments on the local vendors? You can see what the total is.
I did not have any.
Okay. The following page 26 is the contract list for the month. Do you want to go down them, or does anybody have a contract that they have an issue with or have questions about? These are ones that will be coming up We look at them annually, not necessarily coming due, but just so that everyone's aware what kind of contracts we have out there.
As I looked at them, I didn't have any questions on those. I do like that they're all pretty much current, you know, or right at 30 days, and I appreciate that. Jean, do you have any questions?
You're on mute, Jean.
Well, I tried to keep you guys in the past, we've got the aging for all accounts. And we decided maybe we might do it every 2 or 3 months rather than, and I think it's time we do it for the next meeting. Is that possible, Barbara?
The total accounts payable, you mean?
Yes, over 30 days.
Okay.
Okay, thank you.
Does anybody have any questions on the contract list?
Hearing none.
That's you, Catherine.
Yeah, no, hearing none. I didn't have any. I was just looking at the bottom. I was
Prompting you.
yeah, stop. I was just looking at the I know I probably didn't mention it back in January, and I don't know how long we've had it, but just the transfer agreement to Valley Children's. I'm just glad that we have that. And then my other one was going to be on VALIC. Is VALIC the one that we still have at the hospital?
VALIC is the one we use for our retirement plans
okay.
for our employees, right?
Okay. Okay, that was all my questions on that page. I don't have any others. So there's no old business on here. So we just did the contract review and renewals. So now we're to the advanced data storage, pick up and destroy. I was going to ask about that. We've done that, right?
Where's that one?
We do that regularly.
Oh, that's one of the contracts. So
right.
Oh.
The pick up and destroy. How often do we do that one? Is that just like as needed if we're?
No, they come regularly. I don't know if it's weekly or every 2 weeks, but they come regularly.
Okay, and that's the shredding?
Yes.
Yep.
Okay. Okay, so that takes us, if I'm not mistaken, down to the capital expenditure request for HEPA filters. So that's you, Mark.
Yeah, there's your numbers there. If you're, we have a serious COVID problem in our community, and we're admitting more and more patients. I think 2 units, one for the skilled nursing facility and one more for us. I did go to Ridgecrest and borrow a unit from them because I had 5 COVID in the hospital at one time. We do need to have these units ourselves. I think I don't see COVID going away anytime soon, and the fact that the variant, Delta variant, and others are becoming much more transmissible on the airborne side, it's a good idea to have these units available to us. We've been able to secure a couple of them at $3,875. And the Pink Ladies Auxiliary has agreed to cover the cost up to $10,000 for both of them.
Oh my gosh, you gotta love those Pink Ladies.
We actually were able to borrow one from Ridgecrest just because we had this bit of a crisis thing going on here. So that's been hiding us over. So we're trying to get these acquired as quickly as we can so that we can obviously get theirs back to them
This Johnson Controls on the second page, it's a 10 to 12 day lead time. So they can get them out to us pretty quickly if we can get them ordered and paid for. So,
which is great, because I don't remember if you all recall when we put one through the last time, it took us almost a year to take delivery on it.
Yeah. So are we looking at wanting two of them?
Yes.
Yes.
Okay.
One for skilled nursing and one for us on this side. Then I can give Ridgecrest theirs back, and we'll still have a unit in the ICU where we're putting multiple COVID patients at one time. And then there's a room 6 and room 8 that we've been using as well. So each of those, room 6 has its own bathroom, and room 8 has the ability to have room 7 as a donning and doffing area, because we don't use room 7 for a patient room. So we're actually entering in through that way, so we don't have to open doors into the hallway.
Creates an isolation.
So it did create an isolation environment.
That's good. Now,
Mark,
go ahead.
Can the Delta variant, do we have any of the old COVID coming in? Is a percentage of the Delta, or there's no way?
We don't, Gene, we don't test for that here. Those go out to a lab someplace in Sacramento or LA, I don't know. But we don't even know what variant we have here, truly. We just know that we're seeing a much more infectious strain of it here. We don't know if it's Delta variant or not.
Yeah, the county,
we assume so.
The county basically sends random samples up to the state, and those are tested, and then we report back on what overall percentage of those are showing as Delta versus the other variants that are out there. And so, but it's like 8 to 10% or something like that. It's a relatively low percentage that they're testing. So a lot of the samples don't get tested. It's just assumed that because we're seeing so much of the Delta variant in what is tested, that would apply across the board in terms of what percentage that makes up. And like I said, at one point I know it was upwards of 95 to 98% was Delta variant.
But there's less deaths per 100 or whatever the figure is.
It appears to be less virulent. I mean, you still have people dying from it, you know, and so forth, but not like we did with the original COVID.
Right. Okay.
Yeah.
Mutations tend to become weaker, but they can also be more infectious.
Right. And that's what's happened here.
So is this something that can be approved here, or can we put it on the consent agenda, or?
It can go on consent agenda for the board meeting. Okay. Yes.
Do we have a motion to put that on the?
Yes. Yes.
Okay. And so Heidi, you will do that?
Yes, ma'am.
Thank you very much. Thank you, Mark.
You betcha.
So tell Ridgecrest they can have theirs back in like 15 days to make sure we have.
When I see him on premises, I'll take that one.
There you go. Perfect. Okay, so back on to number 3, the Greenboro payments invoice review. Gene?
Okay, Dave, did you get a chance to look at those invoices for Greenboro? I can't hear you. I think you're muted, Dave.
Dave has left the building.
Here I am. I'm sorry.
All right, there he is.
Yes, I got a chance. I didn't get a chance to look at them to the level of being prepared to answer any questions today, but I certainly could get back to you.
Okay, here's what I'd like to talk to you about is there's not enough. If this was my money and it's the same as my money that I'm approving, and I wouldn't approve it. Now, the way they're sending the invoice and their description of what they do, at our last meeting, we had an issue of not figuring out what they were doing and what they were not doing and still billing us. So if we could ask them to give us a chart that describes the whole project and then show the finished area that they're billing us for, it's completed, and if it's electrical or whatever it is, so we can pay it. last couple of years we paid 2 bills for about 216,000 that the only excuse I could give is, well, we owe it. So that's not right.
Yeah, no, I agree with what you're saying. The normal process I would go through as the CFO is I'd work closer with, if it's the plant maintenance manager that set up the relationship with the contractor, I would start with that relationship. I'd representing the hospital. They're the expert in understanding all this detail of what the project involves and what it's going to take to complete the project. I want them to be comfortable that the contractor is performing all the duties as originally agreed upon before I sign an invoice.
But if you look at the invoice, it doesn't say anything.
But my point is, somebody at the hospital who is an expert at what needed to be done to fix whatever the contract.
Do we have an expert?
I need to talk to that person and find out whether we're happy with what they're doing.
Well, they seem to be happy just writing checks out.
Well, it doesn't quite work that way. I mean, clearly we've been obviously working through on the drawings and so forth. We're not yet at the point where we're at the construction documents. Take a look at page 34 just for a second, if you will. Maybe I can help explain this a little bit as to how they invoice. What you see on under where it says fee summary, this is under project description, Kern Valley Hospital seismic retrofit. And you'll see O2 schematic design. And so what happens is these are the general categories of where the money is going to be spent. So there's an overall stipulated amount when we agreed to do this project that the architectural fees were going to come in at a little over $1,128,000. Okay. And so some of that percentage-wise was in the schematic design work that was originally estimated to be $72,160. That phase of that was 75 committed, has been completed up to this date. So there's been an amount billed to us of $54,120 against that work. Now there is the final payment on that was currently invoiced in this invoice here for $18,040, and that actually completes the schematic design work that was done. So you'll see over in the very last column it says remaining, it's $0. So that phase is completed. The next phase is the electrical service upgrade because that part was split out. And so approximately 10%, 10.3% of the overall dollars were set up to cover the electrical service upgrade. So that's $130,000 of the budget is budgeted to cover those costs. So far, we've only spent 10% of that, which is $13,065, which is also included on this invoice, leaving a balance of $117,000 left to be billed for the rest of the electrical work going forward, okay? Then you'll see next section down is design development. There's $299,000 that's been budgeted for that portion of the work, of which that has not been billed to us yet. $299,000. Construction documents obviously is another $568. So that hasn't worked. So this is how, following down here, this is how we monitor where they're at in their progress with regards to getting those plans done. Once they hit those totals, they're capped out. So again, if there's still work to do, they've still got to get it done. So unless there's a major change or project or something like that that was not in the original scope of the work, then they would have to come back to us for approval for additional funds.
Well, and it is open-ended. They can pretty much do whatever they want to do. And
no,
so
it's not open-ended. They've got certain budgeted dollars that have been set up here by category that they have to use, that they have to spend to get the plans done.
Do we have in the contract what they said they would do? Do we have a copy of that showing what we're paying and percentage that they're at?
Yeah, Barb, you should probably have a copy of the contract, right?
I have.
It would have to be an AP file, or your files are somewhere. I know Bob has it for sure.
Well, I would normally start with Bob, and as long as the contractor hasn't exceeded the grand total amounts, I don't really need to get involved unless there's something going on that we're not happy about.
Here's what I'd like to ask happen, if the board is okay with this. What I would like to see happen is, because obviously there's some questions there, what I would like to see, Dave, is for you to get involved with this and go through the invoices. You and I talked about this briefly the other day, of going through and validating, where we're at today based upon what's come through here, so that the board has a comfort level that we're not paying for things that we haven't been done. Now, obviously, Bob will have to validate that, yes, that level of work has been completed, the drawings are done, we've seen them, you know, and so forth, and we can actually lay hands on those. But like I said, to make sure that they're billing us based within the terms that were set up within the contract, I think would be helpful if you could look at that.
Yeah, that shouldn't be a problem. I could just map up what's in the contract compared to what's being invoiced.
Yep.
And we can see if any category looks goofy.
Well,
Would that satisfy you, Gene?
yes, at the planning committee
Yeah.
meeting,
Yes, correct.
there was a lot of confusion about what they're doing and what they're not doing, and then not showing up to do stuff. So there was problems. But okay, yes, Dave, if you would look at
Okay, and you know, it sounds to me like the main issue is a formatting that the board needs to have something that they can understand, that we've looked at the detail of the invoices and nothing looks out of order in terms of what we expected in terms of a payment by category.
Right. Now, in one of those, Bob said there was something that we did that wasn't normal. And I didn't look in there, but
yeah, and in those cases, I'd probably want a whole separate paragraph or justification when something deviates from what it should have been.
Right.
Okay. All right. You get a general idea.
Yep. No, and I think that's a good check and balance that, you know, I'd be glad to get involved in that.
Cool.
Yeah, I think you need to be. Yeah.
Was that it, Catherine?
Yep, on that one. And then the next one, number 4, is discussion on accounts payable. Jean, that's yours, but I think you brought that up to Barbara just a little bit ago.
Right. I think we got that handled. We want to try to be to pay our bills when we get them. One example, it took us 4 months to pay that gas bill, and they come back saying, well, we owe you money, so we're going to deliver anyway. I mean, we need to pay our bills. And there was $3,000. Barbara, I don't know if you saw, you heard Bob say that we still owed him $3,000. Did you get a chance to look at that?
We're not showing that. We've reached out to them to see what that could possibly be.
Okay.
But they haven't gotten back yet.
But
in general, I'm not only not apologetic for our performance on paying the bills, I'm very proud of the fact that we pay our bills much better than the average provider. So I don't really, you may have a couple examples of bills that maybe didn't get paid the exact month they should have got paid, but I'm sorry, as a board, you probably need to look at averages and look at the big picture. And we've got a very good payment history of how we're paying our AP.
Now that's for the last 3 years or the last 2 years?
I'm just saying our current situation.
Okay. All right. Okay. Then Barbara, thank you.
You're welcome.
So those are the last thing to be covered. Does anybody have any questions or anything? If not, then we will adjourn the meeting.
Thank you.
Thank you.
Thank you, everybody.
Thanks, Dave.
Thank you, guys.
Thanks, everybody.
Thanks, Gene.